don't stop. Don't stop. Don't stop. Don't stop.
The glands of the digestive system. The glands of the digestive system are located within the wall of the alimentary canal. The intramural glands and outside the wall the extramural glands, including the major salivary glands, parotid, submandibular, and sublingual glands, pancreas, and liver, and gallbladder, whose secretions gain access to the lumen ofthe alimentary canal by a system of ducts. Major salivary glands. The major salivary glands parotid, submandibular, and sublingual are compound tubuloal veolar glands that secrete saliva. Each major salivary gland is surrounded by a connective tissue capsule that sends connective tissue septa into the substance of the gland, dividing it into lobes and lobules. The neurovascular elements travel in these connective tissue septa to supply the parenchyma of the gland. The parenchyma is the secretory portion consisting of acini or tubules and or both, and a duct that culminates in the principal duct of the gland. The functional unit of a salivary gland, the salivum, is composed of an acinus and its intercalated and striated ducts. Three types of cells form the secretory portion of a salivary gland: serous, mucous, and myoepithelial. Serous cells resemble a truncated pyramid, and they produce a watery fluid composed mostly of water, electrolytes, and enzymes, salivary amylase and lipase, that begin digestion in the oral cavity. Other secretions include kallikrein and the antibacterial agents lysozyme and lactoferrin. The secretions are stored in apically located zymogen granules, secretory granules, until their release is prompted. Mucous cells resemble serous cells, but their apical cytoplasm houses secretory granules filled with mucinogen, a proteoglycan that, when released, becomes hydrated to form mucin. When mucin mixes with the secretion, it becomes mucus. Acini are composed of serous cells only, mucous cells only, or mucous cells only but capped by a few serous cells as serous demilunes. Each acinus is surrounded by a basal lamina, and myoepithelial cells whose contraction assists in delivering the secretory product of the acinus into the lumen to enter the ducts. The ducts of salivary glands begin as very slender conduits lined by simple cuboidal epithelium known as intercalated ducts. The secretion entering these ducts and isotonic with blood is known as the primary saliva. Larger, striated ducts, lined with low columnar epithelial cells, receive the primary saliva. The basal cell membranes of these cells display numerous mitochondria-rich folds that actively transport Na** out of the lumen and K** and HCO* into the lumen of the duct, modifying the primary saliva into hypotonic secondary saliva. Several striated ducts unite to form intralobular ducts, which unite to form larger excretory ducts. The principal excretory duct that delivers the saliva into the oral cavity is usually lined by a stratified cuboidal to pseudo-stratified epithelium. Plasma cells of the connective tissue stroma make IgA dimers that are held to each other by a J chain. These dimers are taken up by the acinar cells and by striated duct cells where the secretory component is added, forming secretory IgA that is transferred into the lumen of the acinus and striated duct. In contrast to the minor salivary glands, the major salivary glands secrete on demand, and the secretion is controlled by the process of smelling, food, chewing, and vomiting. Saliva output is about 1L/day. Parasympathetic innervations induce flow mainly of watery saliva, whereas sympathetic innervations induce the release of more viscous saliva. Of the major salivary glands, the parotid gland produces a serous secretion, about 30% of the saliva, whereas the submandibular gland produces 60%, and the sublingual gland produces only 5% of saliva. The latter two glands release a mixed saliva. The flow of saliva is essential for the maintenance of a healthy mouth because saliva cleanses the teeth, keeps the oral mucosa moist, and offers the first line of defense against invading microorganisms. Also, by moistening the food, it allows the formation of a compact, but pliable, and slippery bolus that can be swallowed easily. Salivary flow is normal when one is relaxed. However, when an individual is scared or nervous, the mouth becomes dry. This condition was well known during the time of the Inquisition and was used by the court in trying the individual. The accused was given flour to swallow with the assumption that if the individual was not guilty, he or she would not be nervous or scared and could produce enough saliva to swallow the flour. Naturally, the accused was always nervous and scared, and because of the limited salivary flow could not swallow the flour. This was taken as undeniable evidence that the accused was guilty as charged. Mumps. Mumps is a viral disease that most commonly occurs in children 5 to 15 years old. It is spread by droplets of virus-containing saliva that become airborne after an infected individual coughs near an uninfected individual or if an uninfected individual has contact with an object on which saliva from an infected individual has landed. The incubation period for mumps is 2 to 3 weeks, after which the patient becomes lethargic, has a headache, and experiences a lack of appetite. The most frequent symptom is painful swelling of the parotid glands that is accompanied by a high fever of 103 degrees Fahrenheit to 104 degrees Fahrenheit. Most children in the United States are immunized against mumps, so incidence of this disease is very low. Mumps is much more serious in men because it may spread to one or both testes, where it may cause sterility, or to the meninges and pancreas, but usually the infection resolves itself. The pancreas is a 25 cm long gland that weighs about 150 g and has an exocrine and an endocrine component. Its insubstantial connective tissue capsule sends septa into the substance of the gland, which not only subdivide it into lobes and lobules but also convey a system of ducts and neurovascular elements to serve the gland. The exocrine portion occupies most of the gland, and the endocrine component, the islets of Langerhans, is distributed as richly vascularized spherical clusters of endocrine cells among the secretory acini, Fig 18.2. The exocrine pancreas, composed of tubulociner units with its associated system of ducts, manufactures and releases, approximately 1.2 L of a buffered fluid that is designed to neutralize the acidic chyme released by the stomach into the duodenum proenzymes that are activated when in the lumen of the duodenum to break down the nutrient-rich chyme. Each acinus is composed of 40 to 50 acinar cells. The lumen of the acinus houses a few centroacinar cells, the beginning elements of the pancreatic duct system. The presence of centroacinar cells is characteristic of the pancreas. Acinar cells resemble truncated pyramids whose apex is packed with zymogen granules containing proenzymes. The basal plasmalemma of each acinar cell possesses receptors for the hormone cholecystokinin and the neurotransmitter acetylcholine. The centroacinar cells of each acinus are continuous with the intercalated ducts, several of which join to form intralobular ducts, which unite with others to form interlobular and larger ducts that eventually drain into the main pancreatic duct. The common bile duct of the gallbladder and the main pancreatic duct join each other to pierce the wall of the duodenum, forming the papilla of Vater. The acinar cells function in the synthesis of digestive proenzymes and enzymes that are stored and released when prompted by the binding of acetylcholine from parasympathetic postganglionic fibers in conjunction with cholecystokinin released from diffuse neuroendocrine system, DNES, cells of the duodenum. The enzymes released by the pancreatic acinar cells are RNase, DNase, lipase, and amylase, and the proenzymes released are elastase, chymotrypsinogen, trypsinogen, and procarboxypeptidase. The acinar cells protect themselves by synthesizing trypsin inhibitor to prevent the activation of trypsinogen while in the cytosol. The bicarbonate-rich buffer is released by cells of intercalated ducts and centroacinar cells in response to the binding to receptors of their basal plasmalemmae of acetylcholine, derived from postganglionic parasympathetic fibers, and secretin, derived from DNES cells of the duodenum. The bicarbonate is manufactured within the striated duct cells that combine Co and H, which form HCO. This molecule dissociates into H** and HCO. The bicarbonate is released into the lumen of the duct along with Na to maintain neutrality. H is released into the connective tissue to enter the periacinar capillary bed. Because the mechanism of release of the enzymes and buffer depends on different signaling molecules, the enzymes and buffer are released independently, although sometimes simultaneously. Endocrine pancreas. The endocrine pancreas is composed of approximately 1 million islets of Langerhans, each encased in a thin, reticular fiber sheath that sends fibers into each islet to support its separate, rich vascular supply, the insulocinar portal system. Veins leaving each islet meander by neighboring acini and bring signaling molecules released by the cells of the islets to control the function of the acini. 5 cell types constitute the 3,000 or so cells of each islet of Langerhans. Each cell type manufactures a particular hormone. N cells manufacture glucagon, B cells synthesize insulin, 6 cells form somatostatin, PP cells manufacture pancreatic polypeptide, and C cells manufacture gastrin. The frequency of these cells in the islets of Langerhans, the hormones that they produce, and the functions of the hormones are presented in Table 18.1. Diabetes mellitus. Diabetes mellitus is a condition in which the blood glucose level is higher than normal. There are 2 types of diabetes mellitus: type 1, which begins at a young age because the patient does not manufacture enough insulin, and type 2, which begins later in life when the patient produces enough insulin, but the body becomes resistant to its effects. The primary cause of type 2 diabetes mellitus is obesity, although chronic increased levels of corticosteroids and pancreatitis are also factors in the development of this disease. With the increasing incidence of obesity in children and in adults in the United States, the incidence of type 2 diabetes has been increasing. Initially, there are no overt symptoms of type 2 diabetes, but after years of living with this condition, symptoms begin to be noted. The symptoms include increased urinary output, feeling of thirst, fatigue, dehydration, dizziness, confusion, blurred vision, and seizures. It is usually at this time that the patient sees a physician, and blood tests show very high blood glucose levels. The long-term sequelae may be very serious, involving circulatory problems, elevated blood pressure, damage to the heart, gangrene of the extremities, kidney failure, and blindness. The treatment is the reduction of blood glucose levels, which in type 2 diabetes can be accomplished with diet and exercise and medication. In some cases, liver, the parenchymal cells of the liver, the largest gland of the body, are the hepatocytes, which manufacture the exocrine secretion bile and form myriad endocrine products that they release into the blood. The liver is almost entirely invested by the peritoneum, deep to which is a loosely adhering fibroelastic connective tissue called Glason's capsule. Connective tissue elements, derived from the capsule, enter the substance of the liver at the porta hepatis and convey vascular, lymphatic, and bile duct elements into and out of the liver. The right and left hepatic arteries provide about 25% of the liver's oxygen supply, whereas the remaining 75% is received from the nutrient-laden blood carried by the hepatic portal vein that brings blood to the liver from the entire gastrointestinal tract and from the spleen. The hepatic veins carry blood away from the liver at its back, not at the porta hepatis, to deliver it into the inferior vena cava, Fig 18.3. Classic liver lobule. The liver acts as a central depot, receiving blood that carries all the nutrients, except for chylomicrons, absorbed in the gastrointestinal tract. The liver also receives blood from the spleen bearing iron and degradation products of old red blood cells destroyed by that organ. Hepatocytes not only process these nutrients, store them, and convert them into products usable by the cells of the body, but also they eliminate toxic substances. The liver is organized into richly vascularized hexagonal solids, classic lobules that are 2 rem high and less than 1 mm across, see Fig 18.3. In some animals, classic lobules are bounded by connective tissue, but in humans the connective tissue is too slim to define their borders clearly. These connective tissue elements are thickened, however, even in human livers, at the junction of 3 classic lobules into a portal area, triad, that houses slender branches of the portal vein, the hepatic artery, the interlobular bile duct, and a lymph vessel, see Fig 18.3. Only 3 of the portal areas associated with the 6 longitudinal edges of the classic lobule are well defined. They are disposed so that they occupy every alternate edge of each lobule. A cylindrical limiting plate, composed of modified hepatocytes, surrounds each portal area but is isolated from the connective tissue by the space of mall. Each branch of the hepatic artery at the portal area gives rise to numerous smaller branches, distributing arterioles that resemble the legs of centipedes as they wrap around the adjacent walls of the hexagonal lobule, reaching toward the distributing arterioles from the adjacent portal area. Even smaller inlet arterioles arise from the distributing arterioles to serve the substance of each classic lobule. The branches of the portal vein emulate those of the hepatic artery, forming distributing veins and inlet venules. Interlobular bile ducts are supplied by the peribiliary capillary plexus. Bile, released into bile ducts, is delivered into the gallbladder for storage and eventual release. The center of each classic lobule displays a longitudinally disposed central vein, the beginning of the hepatic vein, see Fig 18.3. Anastomosing plates of liver cells radiate from the central vein, forming open vascular channels between them, known as hepatic sinusoids, which open into the central vein. Inlet arterioles and inlet venules deliver their blood into the hepatic sinusoids and then into the central vein. On leaving the lobule, the central vein drains into the sublobular vein, which receives numerous additional central veins from other classic lobules. Sublobular veins join each other to form collecting veins that eventually form the hepatic vein, taking blood away from the liver and into the inferior vena cava. Three concepts of liver lobules. As noted earlier, the classic liver lobule is a hexagonal solid in which the blood flows from the periphery of the lobule to the center, and bile flows in the opposite direction, Fig 18.4. Generally, the flow of exocrine secretory product is toward the center of a lobule, hence another lobule was imagined in which, in a two-dimensional view of the liver, three adjoining central veins were imagined to form the apices of a lobule, and the portal area then became the center of the lobule, called the portal lobule, where bile flows toward the center, as expected of an exocrine gland. The third model is based on blood flow. There are three concentric, diamond-shaped zones of hepatocytes observed, called the acinus of Rappaport. The zones closest to the central vein are zone 3, the zones closest to the periphery of the acinus of Rappaport are zone 1, and the zones in the region in between are zone 2. The boundaries of the acinus are formed by four imaginary lines, extending from a central vein to portal area to the adjoining central vein to the opposite portal area and back to the original central vein. The center of the acinus is the distributing arteriole. Hepatic sinusoids, plates of liver cells and hepatocytes. The plates of liver cells of an adult human, composed of a single layer of hepatocytes, anastomose with each other as they extend from the central vein, similar to spokes of a wheel, to the borders of a classic lobule. The spaces between the plates are occupied by hepatic sinusoids bounded by fenestrated sinusoidal lining cells. This endothelium is leaky because its cells have intercellular gaps as large as 0.5 gm. Kupffer cells, resident macrophages, are located on the sinusoidal aspect of the endothelial cells, Fig 18.5. The sinusoidal lining cells are separated from the plate of hepatocytes by a 0.2 to 0.5 gm wide space, the parasinusoidal space of Dease, where exchange of material between the basolateral domain of hepatocytes and the blood occurs, preventing hepatocytes from contacting the bloodstream. To increase their surface area, hepatocytes form microvilli on their surface that abuts the space of Dease. Additionally, this space contains collagen fibers, mostly type 3 but also some types I and 4, and two types of cells, pit cells, believed to be natural killer cells, and slender ITO cells, also known as fat-storing cells or hepatic stellate cells. ITO cells store fats and vitamin A, manufacture type 3 collagen and other extracellular matrix components to be released into the space of Dease, and manufacture growth factors. In response to tumor growth factor TGF activation by hepatocytes and Kupffer cells, hepatic stellate cells not only increase their production and release of collagen, which reduces the leakiness of the endothelium, but they also transform into myofibroblasts, cells that reduce blood flow into the hepatic sinuses and facilitate cirrhosis-induced portal hypertension. Hepatocytes are large, polygonal cells 20 to 30 gm in diameter that are closely packed within individual plates of liver cells. Each hepatocyte has lateral domains, where the hepatocyte comes in contact with other hepatocytes and forms narrow intercellular channels, bile canaliculi, into which hepatocytes deliver primary bile via active transport. Sinusoidal domains, where the hepatocyte comes in contact with the space of Ds to deliver its endocrine secretion and to endocytose material from the hepatic sinusoids, Fig 18.6. 3 out of 4 hepatocytes have a single nucleus, whereas the other 25% of the cells possess 2 nuclei. Nuclei of 50% of hepatocytes are small, diploid nuclei, but some are larger and evidence polyploidy, attaining even 64 N. The bile that hepatocytes manufacture is primary bile, which becomes concentrated and modified within the gallbladder to become the bile that is released into the duodenum. Because hepatocytes synthesize myriad proteins for their own use and for export, their cytoplasm is rich in Golgi apparatus, ribosomes, and rough endoplasmic reticulum, ER. These cells also possess an abundance of mitochondria to serve their enormous adenosine triphosphate, ATP, needs. The mitochondria of zone 3 of the acinus of Rappaport are smaller but more abundant than the mitochondria of zone 1. Hepatocytes are also richly endowed by smooth ER because this organelle serves the detoxifying function of hepatocytes. Hepatocytes are also rich in inclusions such as lipid deposits, especially in the form of very low-density lipoproteins, VLDLs, and glycogen, beta particles, in large clumps surrounded by smooth ER in zone 1 hepatocytes and sparse deposits in zone 3 liver cells. Hepatocytes are also rich in peroxisomes, organelles that house oxidases that form H and catalase that breaks down HO. These organelles function in detoxification, B-oxidation of fatty acids, purine metabolism, and gluconeogenesis. If the liver is injured either by toxic substances or because of mechanical injury, as by excision of a portion of the liver, ITO cells release various growth factors, such as TGFO, TGF-, hepatocyte growth factor, interleukin-6, and epidermal growth factor, which induce existing hepatocytes to undergo rapid mitotic activity. If the extent of the lesion is great, cholangioles and canals of Herring also participate in the regeneration of the liver. Most of the myriad functions of the liver are carried out by hepatocytes. These functions include the formation of bile, metabolism, storage, and timely release of nutrients absorbed by the alimentary canal, detoxification of noxious substances, transfer of cholesterol and secretory IgA into bile, synthesis of albumins, non-immune globulins, prothrombin, fibrinogen, factor VIII, complement proteins, and binding proteins for signaling molecules, and formation of urea. Other functions of the liver occur in ITO cells, storage of vitamin A, and Kupffer cells, phagocytosis. Bile, biliary ducts, and gallbladder. Bile is composed of water, phospholipids, cholesterol, bile salts, bile pigments, lecithin, IgA, and electrolytes. Bile salts, bile acids, are formed in the hepatocyte smooth ER by conjugating choline, the metabolic byproduct of cholesterol, to glycine or taurine, forming glycocholic acid or taurocolic acid, respectively. Biliverdin, a byproduct of the conversion of heme derived from hemoglobin of erythrocytes destroyed by splenic macrophages, is reduced to the water-insoluble bilirubin, bile pigment, and released into the bloodstream, where it is bound to albumin. The albumin-bilirubin complex is uncoupled in hepatocytes, and the free bilirubin, complex to the cytosolic carrier protein ligandin, enters the smooth ER, where it is uncoupled again. The free bilirubin enters the cytosol to be conjugated by the enzyme glucuronyl transferase to the water-soluble form bilirubin glucuronide, conjugated bilirubin, which enters the bile canaliculi to reach the gallbladder or be released into the bloodstream, Fig 18.7. From the gallbladder, it is released into the duodenum to become eliminated in the feces, and from the bloodstream, it enters the kidneys to be eliminated in urine. Hepatic ducts, the intercellular spaces bounded by adjacent hepatocytes form an anastomosing system of bile canaliculi that deliver their bile into cholangioles at the periphery of the classic lobules. These cholangioles are formed by hepatocytes contacting low cuboidal cells. Cholangioles empty into canals of Herring, slight branches of bile ducts composed of low cuboidal cells that parallel the inlet arterioles. Bile ducts, composed of a simple cuboidal epithelium, join other bile ducts to form larger and larger ducts terminating in the right and left hepatic ducts. The cuboidal cells of cholangioles, canals of Herring, and bile ducts form, in response to secretin released by DNES cells of the duodenum, a bicarbonate-rich buffer that is stored in the gallbladder for release into the duodenum along with the bicarbonate-rich buffer formed by the centroacinar cells and striated ducts of the exocrine pancreas. The right and left hepatic ducts join each other to form the common hepatic duct, which joins the cystic duct of the gallbladder to form the 7 to 8 cm long common bile duct. The pancreatic duct joins the common bile duct in the wall of the duodenum to form the duodenal papilla, papilla of Vater, the common opening of the gallbladder and the pancreas into the lumen of the duodenum. This opening is controlled by a group of smooth muscle fibers, the sphincter of ofthe, which can open the two separate ducts independently of each other. Unless bile or pancreatic secretions are to be released into the duodenum, both ducts are closed. This closure of the common bile duct permits the entry of bile into the gallbladder because as the bile flows down the common bile duct and cannot enter the duodenum, the bile backs up, and at the junction of the common hepatic and cystic ducts the bile backs up into the cystic duct. Flow of bile into the common hepatic duct is opposed by flow in the opposite direction from the right and left hepatic ducts. Gallbladder, the gallbladder, attached to Clison's capsule on the inferior aspect of the liver, can hold about 70 ml of bile. It is composed of a body that resembles a duffel bag whose opening, the neck, is continuous with the cystic duct. The function of the gallbladder is to concentrate the bile that it stores. The lumen is lined by a mucosa that is highly plicated when empty but smooth when the gallbladder is filled. Its simple columnar epithelium is composed mostly of clear cells, with numerous microvilli, whose function is to concentrate the bile by absorbing water via the Na*kat posse pump located in the basolateral plasmalemma of the cell. By actively pumping sodium out of the cell into the underlying connective tissue, Cl** and HCO follow. The loss of these ions from the cell causes the same ions to enter the cell from the lumen, and the osmotic change drives water from the lumen into the cell, reducing the volume of the luminal content and concentrating bile. The epithelium also has a few brush cells that may produce mucinogen. The fibroelastic lamina propria is a vascular connective tissue that houses small mucus glands, but only in the neck of the gallbladder, whose secretion lubricates the narrowed lumen of this region. The gallbladder has a two-layered, ill-defined smooth muscle coat, composed of an internal oblique layer and an outer longitudinal layer. The hormone cholecystokinin is released rhythmically by DNES cells, I cells, of the duodenum, and acetylcholine derived from the vagus nerve causes contraction of these smooth muscle fibers and intermittent emptying of bile from the gallbladder. Additionally, cholecystokinin and acetylcholine cause a concomitant relaxation of the sphincter of ofthe so that bile can enter the duodenum. The gallbladder has an adventitia where it adheres to Clison's capsule and a serosa on its non-adherent aspect. Fatty liver, steatopatitis, may be of two types in the United States and Western countries, alcoholic and non-alcoholic. The first type is more common and is due to the excessive use of alcohol. The second type, non-alcoholic steatopatitis, is due to syndromes such as diabetes mellitus, obesity, or elevated triglyceride levels. Both conditions result in an enlarged liver and can result in cirrhosis of the liver. Steatopatitis in itself is not serious but should be controlled to prevent scarring of the liver and subsequent cirrhosis. The treatment is to control the underlying causes, eliminate excess alcohol consumption, dietary modification to reduce triglyceride levels, and lose weight in the case of obesity. The control of diabetes mellitus, when present, with insulin therapy or dietary regimen or both is essential. Gallstones, The most common condition that affects the gallbladder and the biliary tract is the presence of cholesterol crystals, gallstones, that accumulate in that viscous, cholelithiasis, or along the extrahepatic bile ducts, choledicholithiasis, and obstruct the normal flow of bile. The presence of gallstones is gender-related and age-related. More women and individuals older than 65 years have this condition. Usually, stones in the gallbladder are asymptomatic, but they can enter the biliary ducts and cause obstruction with associated inflammation and infection. When the extrahepatic bile ducts are obstructed, the patient experiences excruciating pain in the upper right of the abdomen and nausea and vomiting. Shortly after the obstruction, inflammation and infection can develop with fever and chills, and shortly thereafter the patient becomes jaundiced. The obstructed bile duct is treated either surgically or by an endoscopic procedure. Cancers liver, HCC, usually do not originate in the extrahepatic bile ducts, but occasionally the junction between the common bile duct and the hepatic duct develops a malignant tumor. When the mass obstructs the flow of bile, the patient becomes jaundiced without the presence of fever or chills, but with nausea, vomiting, abdominal tenderness or pain, weight loss, and generalized itching. Endoscopic treatment may permit the placement of stents to open the bile duct, but the chances of survival are not favorable.